Okay, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. It's my pleasure to have you all with us today in our very special forum. Today is a special forum for me because it's completely different than what usually we do. It's not a pure scientific program. This is something way better and broader idea. I try my best to talk to our senior people in interventional field in the Gulf area to join us in a GIS, which reflect or give a message that the GIS it's a society that collects all interventional cardiology in the Gulf area under one umbrella to deliver to you the most updated education. Today our session is basically sitting with the senior interventional cardiology in the Gulf, talking about a lot of aspects starting from history of interventional cardiology in our region, prediction of the future for interventional cardiology in our region in the Gulf area. They're talking about what we are predicting in the future, especially nowadays we are in a period that COVID-19 is affecting the world and we are part of it. And definitely our practice, our medical services, our health system is different in the future than in the past. Also, we'll go over some advices to the junior staff coming from our senior in the area. Without any further ado, I will introduce all our speakers. I took their humble permission. Will not go over their titles because everybody have a CV in front of me, almost 10 pages. So from Saudi Arabia, we have Dr. Muayyid al-Zibaq, well-known interventional cardiologist. From Kuwait, we have Dr. Mohammed al-Zubayd. He's a well-known interventional cardiology and the Society of GHA. From Emirates, Dr. Abdullah Naimi. And from Bahrain, Dr. Hussam Noor. And from Oman, Dr. Mohammed al-Mukhaini. So I welcome you all. Thank you very much for being with us. It's our pleasure on behalf of GIS and on behalf of all GIS board member and fellows. I would like also to thank Medtronic, who also with us as a sponsor, as usual. So first of all, I will just go by my first question, which is about history. As they say, if you know history, you can predict the future. In Gulf area, we have a lot of history related to interventional field. I was talking to Dr. Muayyid al-Zibaq, and I knew that we did in Saudi Arabia the first PCI even before it's done in the United States, first percutaneous coronary intervention. And they did 40 years ago almost a symposium for interventional cardiology. So every country in the Gulf contribute to this. I would stop here, then I will allow our seniors to go over this. So basically, the first point is history of interventional cardiology in each country. So maybe we start with Dr. Muayyid al-Zibaq, kindly.
Assalamu alaikum. The first angioplasty was in Europe and USA, not in Saudi Arabia. The first angioplasty, balloon angioplasty, we did in Riyadh Military Hospital was in 1983. Then followed by that, very rapidly over a period of 10 years till 93, almost all procedure were gradually and rapidly involved and being introduced. We did first intracoronary streptokinase and balloon. It was a therapy at the time, intracoronary streptokinase and angioplasty for a primary MI. Again in 93, 95, we did the mitral balloons, double balloons. We did 87 tricuspid balloon. I think that was the first one published. And then we were, I think, doing probably one. I used to go to many meetings at the time, in late 80s, intervention meeting, but they were not live. We used to bring our video with us. So I used to have my video, and I think Dr. Ali Khan, our late Dr. Khan, who passed away, unfortunately, he was a cardiologist, he used to get his video. But we did in 1987 live demonstration of structural heart disease as structural heart disease, as you see today in PCR, where we did with various intervention cardiologists. We did the mitral balloon, pulmonary balloon, plate septicemia, coronaries, and so on. And there were 20 intervention cardiologists and international speaker came from Europe and USA. It was maybe one of the largest meeting we had. Actually, this is the only meeting I did in my career. It was very stressful, but was very successful, I think. We did everything live. I think there was basic science from Bill Robert, the pathologist, to Spencer King at the time, 87, Robert Vogel, people know him from US, and many from Europe. Then we introduced the coronary atherectomy, if you remember the cutters. I think 1992. In 1987, it's interestingly now, we were trying to do for the first in human, but we could not get back up from surgery. They refused to back us up. The primitive rotaplator, which is called Kinsey catheter for the right coronary artery, we still do it. But we could not get back up from surgery, so we could not do it. That was maybe the first. And then there was a coronary graft for iliac aneurysm. And again, they would not back us up. So these two procedures were kind of a surprise to do with international kind of speaker. And then we did the bypass, percutaneous bypass machine in 1992. We did 3 cases. The first case was emergency cardiac arrest in the cath lab. And then we did 2 selective elective cases, left main. We did 2 left main, 92, 93. And then we did the laser, again, 92, 93. And there was a lot of publication. So as I mentioned earlier, there was a lot of team effort. We were very integrated as a family. We used to bring to the cath lab elective cases 9 o'clock at night. And the reason, one of the advantage, of course, I don't think it's going to happen now, is there were only 2 regional centers. It would be nice to know how many centers now in other Gulf states. It's one of the advantages to have regional is you could have all the work together and you have enough volume. And you need a very good relationship between personnel, because all this work I mentioned is a huge teamwork. People bringing patients. We want mitral stenosis. We have guys who are very experts in collecting patients, not medical. They bring us 3-4 patients every week. You want pulmonary valvotomy to pediatric, they bring them so on every week. So it's a lot of work on a clerk level, on junior level. Interestingly, with all this, when we used to have only 4 juniors. Now we have 22 and they're complaining, but anyway.
Right. We'll go on the difference between an old and new in a second. So yeah. That's great. So we'll move on to Dr. Zubayd.
So thanks, Dr. Fawaz. I like to really start this session by this is a special time, and I wanted to remember our colleagues, our physician colleagues, our nurses, everybody working with us in the hospitals. We've recently, unfortunately, lost a nurse, and then 2 days ago, lost a consultant ENT physicians, Dr. Tariq Mkhaymer, who left behind his wife, a wife and 4 children. And that's been very sad for us in Kuwait. And I'm sure others have had dramatic stories like this. So just want to pray and make dua to all our colleagues out there and this special time. And we're all involved in this. And we just hope that we come out of this in one piece. And we pray for those who have lost their lives. This is going to be part of history. When people talk about 2020 in a few years' time, when we're older, or people who are now much younger, physicians who are younger, who will get to our ages, they will talk about this year. This has been a dramatic year. So Second, I want to thank the GIS, you know, the Gulf Heart Association, and this is part of history. Since we're talking about history, you know, the Gulf Heart Association was established in 2002, some 18 years ago, and since then has had a lot of impact over the area, and we'll come to that. But part of its impact has been the creation of Gulf Interventional Society that Dr. Fawaz, you're currently presiding on. So this has been part of history, and I'd like to thank you for a great job that you and your colleagues have done. As far as history in Kuwait, I'm going to summarize it into 4 quick points. I moved to Kuwait, came back to Kuwait from Canada in 1996. Is that when you talk about history, we reveal our ages, so that's a problem. But in 1996, in Kuwait, there was one center, and we were doing around 150 cases a year. Today, there are 4 cardiac centers in Kuwait with a population of 4.25 million. We're doing about 10,000 interventional cases a year with all the varieties of TAVIs and mitral procedures and so on. So that's part of the history. There was a landmark time in Kuwait in 2010, around 2010, when 2 other cardiac centers opened, other than the historic center that has always been there, and it's been known for the entire Middle East, the chest hospital. And these 2 centers have made a great impact. And just to tell you the impact, in 2012 in Kuwait, the primary PCI rate was 5%. 2012, 8 years ago. 5% primary PCI rate, the life-saving procedure. In 2016, 4 years later, with the opening of these centers, the 5% went up to 55% primary PCI. So the opening of those 2 centers in 2010 was historic for Kuwait. And then the third historic point in Kuwait was the opening of the hospital, the cath lab where I work at Mubarak Al-Kabir Hospital. And what's unique about it, not because I work there, but what's unique about it is that it's a very busy general hospital. There's cath lab without on-site cardiac surgical backup. For a year, we've done 1,500 cases with 60% PCI, including primary PCI, without on-site surgical backup. These are the 3 points about the history of intervention in Kuwait, without taking too much time.
Excellent, excellent. Dr. Abdullah Naimi. Dr. Abdullah الصوت. Can you unmute Dr. Abdullah?
Sure, Dr. Hal.
Okay, Dr. Abdullah?
Yes, sir.
Yeah, we can hear you now.
Okay, Assalamu alaikum and Ramadan Kareem. So when we reflect on the history, there are major issues we need to look at. Reflecting back, say, on the 20 years of Gulf Heart, GIS, and on individual cardiac centers in the UAE, and maybe in the nearby countries of the GCC. We need to, at the beginning of our starting our centers, coming back from abroad, everybody wants to achieve. And sometimes cooperation and collaboration is not put on the agenda. And unfortunately, this might lead to some negative competition. So we are not here just looking at the history, numbers, and so on. In fact, we are supposed to reflect lessons to be learned. So I think for the existing generation and for the future generation, try to win with the team atmosphere rather than a single solo person. And also when we do societies in the Gulf, we try also to make the collaboration and make the cooperation as a major way of working together. What had made the difference really is, for example, in 1998, 1999, 2000, we were trying to transform from a femoral approach to radial approach, whether in the UAE and also in the Gulf. The huge number of complications in the peripheral work when we do the coronaries have almost abolished now when we went to the radial approach. And I think we should really, we were discussing on the phone with each others on the GCC. We were meeting a lot and we were discussing the details of how do we overcome this issue in intervention and so on. And this is the positive side of the history in the area. So I think the radial transformation made a difference. Also, I remember in the early 2000s, we did a Gulf mission to go to Sana'a, to Yemen. And it was a collaboration from 3 GCC countries. And we helped our beloved friends in Yemen. We stayed with them. We knew their problems. So when we came back from that mission, we spoke to our officials about how difficult is cardiology, for example, in Yemen and so on. And I think I encourage our GIS and our friend in the Gulfs to do and keep some missions. And I am very happy that we saw a mission lately in Jordan where the GIS have helped in this regard.
Thank you very much, Dr. Abdullah. Great points. Dr. Mohammed Al-Mkhani, maybe it's the same line.
Actually البداية بدأت عندنا في الثمانينات أو نهاية الثمانينات بداية الكاردياك اثرايزيشن أو كوروناري انجيوغرافي. كان الله يذكره بالخير الدكتور رشيد شهرباني هو اللي بدأ خدمات الكاث لاب. قبل هذا كان أكثر المرضى يعني يروح يا الأردن أو إلى UK for cardiac authorization. أول حالة أتذكرها أو يعني حسب ما خبروني كانت في 1993 اللي هي أول حالة PTCA كان مع دكتور رشيد وبروفيسور كوب سووها بس للأسف patient dissected و had to be sent for an emergency surgery. Then they started really slowly يعني تقريبا يمكن 50 حالة في السنة 60 حالة في السنة 100 حالة في السنة إلى تقريبا من 2000 وتطالع بدأوا إلى 300 400. Last year we closed only in our center about 3,000 6,300 cases, including pediatric and including electrophysiology. Pure coronaries were around 4,000 something يعني. طبعا العمليات يعني تطورت كما ونوعا يعني بالنسبة للcomplex complexity of the cases, structural heart disease, which I see the future of intervention, especially in Gulf states. is we should focus on structural heart disease وهذا هو النمط اللي ماشي فيه العالم تقريبا التركيز اكثر ربما تلاحظوا ان الريسيرش والتقنيات مركزين اكثر على structural heart disease اكثر من ربما الكوروناري is plateauing at this stage apart from the techniques for the CTOs otherwise يعني ما في شيء breakthrough for the last I would say maybe 5-10 years. فهذا اللي صاير. النقطة اللي نكون نركز عليها في الفيوتشر إن شاء الله هي قضية مثل ما قلنا structural heart disease, research.
In a second, Dr. Mohammed.
Okay, تمام.
Excellent. Dr. Hussam Noor, this first question.
I'm going to be very, very quick. Thanks again for everyone's Ramadan Kareem to all. I think one point. Our center, Mohammed bin Khalifa Cardiac Center, was established in 1993. At that time, I was a medical student. So but I joined the center after finishing my training in the US in 2004. But one thing which I would echo what Dr. Muayyad has said is my seniors and the collaboration and the teamwork that we had between our colleagues in the Gulf. A couple of my seniors, who actually were my mentors, were trained in the National Guard with Muayyad and his group. So at that time, the network was very, very strong. A lot of my predecessors who actually established the center in Bahrain were trained with my colleagues in Saudi Arabia and Riyadh. And Muayyad knows them by name, and they came and they established the center in 1993. And of course, we learned quite a bit from the what happened in our neighbor countries, and we took the experience from there, and we established till we grew little by little to actually after in the era of 2000, we expanded into all the new technologies that everyone else has. Mind it that Bahrain is a small country. We are 1.5 million in population, and we have 2 cath labs covering the whole island, and we're the referral center. But really, what I would echo is what Muayyad has said, that at that time there was a golden era, and I hope that this teamwork will continue over the years to come.
Excellent, excellent, good. So we'll move on to a second question, but just for the audience, please, if you have any question or comment, you can put it down. I can share it at the end of our session. So the next topic, great points of history in every country of our Gulf area. So looking at today, when you look at the past and compare it with what we have today, what is the major difference in our practice today? Do you think that we grow up in diagnostic imaging? Do we think we grow up in structural heart disease and less coronaries? Is there any difference in the practice, like one interventional cardiology in each lab compared to 2 interventional cardiology working in the same case before? Distribution of the manpower, distribution of the cath lab. It's a lot of changes in 2020 compared to 30 years ago. So we'll just go over that with some messages and advices. So shall we go back to Dr. Muayyad again?
Thank you. I mean, there are major differences now between today practice and 2030, and some our colleague has suggested, and I think this is natural. You cannot avoid it. Like in Riyadh now, there's at least 10 cardiac centers only in Riyadh, and you could just count how many we have. When you have such large number, what happened? Regional centers like in military hospital, King Faisal, and they were designed to work much bigger force. I mean, staff-wise and equipment. For example, the military can run three shifts of cardiac surgery and cardiac interior work 24 hours if you want. And that costs a lot of money in the late 80s, which we asked. Of course, now they work much less in the military because there are so many, the same thing with us. I mean, we have too many cath labs when we designed that 25 years ago in the National Guard. It's, and I don't think we are using it completely. Hopefully, we're going to keep them for tomorrow, for the next 10, 15 years. So this has to be taken into consideration when you design a national strategy, is what to do with this all investment you did. And I think having regional center is very important to maintain the volume and quality. I mean, you cannot maintain quality with all this cath lab everywhere. I'm telling you, before it was much easier. There are 3-4 centers. You could maintain quality. Even the government Sibahi, which is the quality control, I don't know how they're going to control the quality of acute MI treatment and catheter intervention. Is going to be a bigger problem, I think. It comes also, there are issues came to the business, like private practice. I think this is, in my view, is very destructive for the cardiologist in the major institution to focus, improve their work, or to do research. I mean, everybody say, oh, research, so basically I'm going to lose time. So you go to private practice. So research is almost, I don't think it exists an intervention cath lab in Saudi Arabia, despite the fact we have many of them. So how you bring all this together as a multi-center, you need the good correlation and good relation between cardiac interventionists in Saudi Arabia. And also that's apply to the Gulf. I remember we did the first intervention society for the Arabic country in the late 80s. And we met in ice skatings in Dubai. And then you could see the major difference of opinion between various Arab countries, and should we do it through the Arab Union and the United? I mean, I said, look, if you make it bigger, you're going to lose it. And I think keep it away from governmental institutions. Should be only with us as individuals. Avoid the regulation, because relation may not be the same between countries, and they will affect the society. So it has to be out of the government.
Great. Good. So thank you very much, Dr. Muayyad. Who's gonna be the next? Dr. Zubair?
I am back, but I was disconnected for the entire when Dr. Muayyad was talking. So I have no idea why. I'll pass. Let others contribute. I got disconnected.
Dr. Mohammed Mukhaini or Dr. Abdullah Hussam.
So I think we, the generation, say when we did the, I'm not that old as Muayyad, but in the 94, 95, 96 until 2002, we were facing a lot of difficulties with the intervention from the access point of view, from ballooning, wires, stenting, etc. We used to mount our stents on the balloons. So I think this has gone. And I think this we are very fortunate nowadays that the access and the complications is very minimal. The second point is the number of cath labs per capita. I think we have the highest number in the UAE, and this is unfortunately has diluted the experience in so many small centers with the small volume. And this is something that I encourage our societies, the GIS, the Emirates Cardiac Society, and the rest, to look at this seriously. And I think we have an obligation towards our patients, towards our society, that we have to, this plethora of cath labs in every corner of the country has to be looked at and seriously brought to stop and maybe manage it in a better way.
Fawaz, if you allow me, I think what Abdullah and Muayyad has said makes, this is one of the biggest differences that we are facing. Actually, if you look at the group that we're talking to and our friends from around the region, the standard is different. So there are the people that we know them. You can, in a way, plus or minus, you can have a standardized way of the interpreting and treating coronary disease. But once you go to areas in which, or operators who they have lower volume, or people that we don't even know who they are, they do cases like 20 or 50 cases per year, and you can see significant variation. So you have a group, what I've seen in the Gulf, you'll see a group in which we can almost 80% agree on what we're doing, and 20% we disagree in a healthy way, versus you go some other groups, especially in private practice or low volume operators or low other institutions, and you see a significant variation in the way and analysis of the angiogram or the intervention, and it's all related to experience, I would say. And that's one thing that I've seen. I mean, we in Bahrain, luckily we have one center, but we see referrals coming from other countries, and you see significant variation. And and it's not from Muayyad or from Abdullah or Mohammed Mukhaini, it's from people who work in private institutions in which they do very low volume procedures per year. So that is, I think, it's a very important point that we discuss. And then the other thing is always I call that like cherry picking. We know who we're talking to. This is the whole Gulf is a small by itself is very small and very homogeneous people that we know each other. But there are, I mean, I tell you an example. I wouldn't say where it was. I went to Proctor doing CTOs, one of the countries, and one of the centers, which are a remote center, in which they would, for example, injecting the coronaries, they would inject the coronaries without even having hemodynamic assessment. Why you inject? You inject, you aspirate blood, and you give contrast. And I've seen that in the past 2 years. I mean, that's not the practice. That's not what Maeda told me when he came to Loma Linda in 2003.
Okay.
So that's what I'm saying. Yeah, things should be more stringent. Yeah.
I have to say, Hussam was an attending when he was a fellow intervention in Loma Linda. And again, as I mentioned, the point I think for you may be relevant. We should welcome the younger generation. There's always some kind of resistance. And I think Hussam was superbly trained, and I know he's going to be one of the best in Bahrain, and he did. But I think we all, the senior guys, have to accommodate the younger generation. I know when they come from training, they think on Thursday they're student, fellow, and then on Sunday are consultant. But you have to accept that feeling, and usually they're going to take 2 3 years with supervision. I mean, support rather than supervision. And I think it's very important, this continuity. I don't see this very common in our centers, basically. I think this should be addressed by the society, by the GIC, you know, with the Fawaz and the group, how to support the junior.
Also, I mean, if you allow me, Fawaz, just for another 30 seconds. So the networking is very, very important. When I was at Loma Linda doing cardiology fellowship, so it was one of the days in the cath lab, and they say, well, there's somebody from your neighbor country is here as an attending. I was really surprised, and I saw Maed is there in the cath lab. He was my attending, and he said to me, the first thing he said, look, make sure we don't have any complications. I remember that very well. But, you know, and how did Maed was in Loma Linda, and the whole university had a fantastic relationship with our colleagues in Saudi Arabia. That networking is very, very important. Our guys, our network with the EuroPCR is fantastic. So we need to, you know, work. This has to continue, because without this kind of network, you know, we're part of this global thing, you know.
I can assure Hussam that Dr. Muayyad still say the same word. Don't be sure that you don't have a complication.
Zero.
But
I have to admit, it was great days there. Believe me, it was fantastic days in Loma Linda with him. I really had a good time.
But I think let me speak and or say something on this. This is one of our role at the GIS is to bring all people together, bring the senior with the junior staff, create a network. We are trying to do a lot of workshop and educational material that will educate our juniors to be at the level of our senior. And I think, as you mentioned before, the network is very important. And we always need a supervision from senior in the capital.
So Fawaz, briefly, and I was cut off there for a while, and now I got the hang of it. So I had to move to my mobile phone. I turned off the laptop. So, okay, you see, opening centers has its advantages and disadvantages. In Kuwait, we lived through a period that really initially there was a great deal of resistance. We've had this one cardiac center in Kuwait that used to cover the entire population. The entire population used to be 2.5 million, and then it expanded and so on. And there was a great resistance to opening other centers for the fear of dilution. And it's really interesting, you know, as these other centers opened, so 3 other centers, and I'm talking about the big governmental hospitals. So you have, you know, the private sector, but it's really small. in Kuwait, at least. So, you know, for each center that opened, there was a great deal of argument. Oh, why is this center opening? You know, what's the point? It's going to dilute the numbers. And to the contrary, each center that got created and was established had a big role to play, because we were not dealing with the real acute coronary syndrome. The majority of cardiology now, where the life-saving procedures is in acute coronary syndrome. That's the, you know, where the science is, where the evidence base is, and where morbidity, mortality is. And, you know, the big regional center missed the acuteness of the ACS, and whenever it dealt with it, there was a great deal of logistics involved. So one center opened, then another center opened a couple of years later, and the practice has mushroomed. And the practice in that original big center, Chest Hospital, didn't decrease. It's very interesting. You know, you have two major institutions open up in the country, and you think the practice in that one big hospital will diminish. Not really, it hasn't diminished. And then when the center where I work at in Mubarak Hospital opened a year ago, and that was really a big issue because there was no backup surgery, on-site backup surgery. There was so much controversy about creating a busy center without backup surgery. It was done. Again, the numbers are big. You're dealing mostly 90% acute coronary syndrome and so on. So the establishment of centers has its advantages, has its disadvantages. Probably if it's done in the right way, in the right setting, the advantages are a lot more than the disadvantages.
Great. Dr. Mohammed?
دكتور محمد بالنسبة لهذه الباك اب يعني باك اب cardiac surgery, I want to ask all of you, what's the percentage of cases whom really you sent directly from the cath lab to the operating room for the last, let's say, 10 years?
I haven't had, no, we haven't.
No, a single case.
Yeah, but despite that, when we came to establish this center, there was, you know, a lot of resistance and talk and this and that, but we managed to overcome that.
يعني الجماعة في العين يعني صار لهم more than 10 years, and the nearest cardiac surgery is in Abu Dhabi, which is more than 1 hour and a half. فهذا the tendency of practice has changed a lot. I mean, for the last, I would say, since 2002, I've sent only one case directly from the cath lab to the OR. So the practice has changed a lot, maybe because the tools and the which we have for angioplasty had improved a lot. One thing I want to stress on networking among us. يمكن هذه الأزمة اللي صارت علمتنا كثير في قضية أهمية distant learning ومن قضية networking, webinars. Why don't we have more frequent webinars among all the Gulf states, among all the leaders for the in intervention, to present on monthly basis or every 2 weeks basis case which we need to discuss, take opinion from each other, and also involve the juniors with it. Yani. What do you think about it?
Good. I will take that. I think I'm working on it. And I think by today, ICOM with us here, we'll finish a curriculum called the Master Course for Interventional Cardiologists that will go from May till almost August. That's what we expect the problem will be. It's going to be online. Hopefully you can do it weekly or maybe bi-monthly. And it will cover all the aspects of interventional cardiology as a presentation, panelist discussion, and we'll have also case competition from the juniors if they want to present their cases. So we work on it for last almost 3 weeks. It should be ready by tonight, tomorrow, or within two days. I'm going to share it with our GIS board member to go ahead with it. Excellent point. I think we learned a lot. So now we'll move to the third question, which is actually As a Gulf area, we already well-established practice in interventional cardiology. We draw our practice in the map of the globe. But I think it's now is the time to make our identity as a Gulf area. We have a lot. We have a great fund for health services. We have a great institute everywhere in Gulf area, a great interventional cardiology that are well trained abroad and have a great experience since they start. So my question is, where shall we go from now? I think it's a lot of point in my head. Number one is we still are bringing up proctors to do some cases. Do we need to do that? Do we need to bring a proctor from Europe or from state to do a TAVI or to do any other case while we already have a great experience? So the collaboration between us as a Gulf area, it's one point. Second is research and registry. And that's something we are dreaming in the GIS to make a registry for left main, for TAVI, for mitral club. Is that something you guys think it's important? And third is, as you see, BCR and TCT, they are going outside their borders. Do you think it's a time for a GIS in the Gulf interventional field to go outside the Gulf and work hand by hand with other countries that need support? So anyone will just comment on this points? Maybe Dr. Zubaydi will.
Well, let me say, it's sharing is always good, and you have locally we have great people. Some of us are sitting here, mashallah. Hussam is a proctor for CTOs. We have a lot of colleagues from Kuwait and the region and the Gulf who have excelled in certain procedures and have been, going around countries practicing, showing, proctoring, and you always need people from outside. As far as one of the advices I'd like to give to our colleagues is to try to always analyze what they do. If one thing has been missing from when I attend meetings, when I listen to colleagues, and this really what differentiates us in the East from the West, and this, we have really great colleagues, excellent practitioners, but what really differentiates us in the East in general, not just the Gulf, in the East in general, in the Middle East, from the Westerners, is that they have the capacity to analyze, criticize, scrutinize their practice and move on. We, despite the big numbers we're doing, we have not had the capacity. That system is not embedded, or that technique or that science is not embedded in our practice. And that one piece is really missing from our practice. So that's, I'm just talking about this. I think we're going to talk about research. So I just don't want to say a whole lot about research. But as I look at colleagues, go to meetings, that's the one point that I see is missing in our practice.
Okay, excellent. I see Dr. Hussam would like to say something here.
Yeah, what Mohammed has said is absolutely right. In terms of, I think we have enough expertise in the region that we can help each other. I can tell you from my own experience with my colleagues and my friends, when we go and proctor with each other, it's much more friendlier, much more easier. If Fawaz comes to Bahrain and he says, Osama, let's do a workshop of left main bifurcation, and he shares his experience in Bahrain, is much more fluid, I would say, and easier to do versus I get somebody who comes, say, from Finland to Bahrain. because we're not different than the rest of it. Of course, we always need some expertise every now and then, but we have great people. And I think that networking of having, if I need to do, for example, a new valve technology, I'd rather have a proctor from somebody close by, somebody that I know that I can work with versus somebody completely I've never met before. So that is in terms of the proctorship and the training among us. The other thing is, which I'm going to open up for the discussion. I think before the COVID era, we had so many meetings happening, a lot of meetings happening. So it was very difficult, to really follow what's happening. And I think for our region, we have to minimize the major meetings once or twice, 3 times per year, and then we could supplement that with webinars like this. We can sit, and as Fawaz, that the idea that we came up was fantastic, in which you could supplement it, in which we could have a broader people come into the picture than, traveling back and forth, because we have a limitation in terms of time, and I'd rather have, for example, very specific meetings happening on the webinar than traveling across the region. And also, for example, I have received few requests from, people who are early in their career. They want to come and some training in Bahrain or vice versa. I think we should have a mechanism in which we have a centralized way. If somebody from Jeddah wants to come to Bahrain, if somebody from Bahrain wants to go to Riyadh with Muayyad and the rest of the group say, okay, I want to go to Muayyad and learn mitral valvuloplasty. So we should have a mechanism in which we could support these to go in the right place if they want to. And it should not be on an individual basis. It should be like if the GIS or another society or come up and say, okay, we could open up a channel for the younger generation. They don't need to have a fellowship. They already had the fellowship. If he wants to go, for example, to Kuwait with Abdullah Al-Anizi, who's really an expert guy in valve diseases and aortic, he can spend a week with him. We could have a mechanism in which we could facilitate and make it easier to interchange these skills among each other. And that would be really a great idea to work on for the younger, even for us as well.
Excellent. Good. Dr. Mohammed Khani or Dr. Muayyad?
I think I agree with Hussam. I think with the corona, it's going to last more than a year, I think. And
I hope not.
The discussion of, the precaution is going to continue. I think having a very small topics, specific topic between some seniors on the webinar, I think is more than enough, to be honest with you, because only you are understanding the language when we talk about certain problem in procedure. And I think that would be very good. I think to do that, they can, the Gulf Society could do it. We, as an intervention, I don't know which one is become big in Saudi Arabia, but I tell you, we have the proctor for the LVAD is with us, and he goes around. So we are, I think, to have a proctor locally is not a bad idea. I think many of the people are experienced enough, and they should do it. One thing about Mohammed was mentioning about the outsider. Our patients are different than outside patients. Unfortunately, our people are expecting to have zero complication, nobody should die, and so on. And that made our cardiologists, intervention cardiologists, less aggressive, I think, than outside. The outside, they do the procedure and they progress, evolve. And I think maybe that's one advantage to bring somebody from a different culture to push the procedure into more discharge the same day, for example, discharge PCI the same day. I don't think we'll ever could do it. Maybe in the West would be pushed based on statistics, and then would be acceptable behavior. So our patient will accept the behavior and so on. So I think having people from outside in selective, circumstances, I think it's not a bad idea. Doesn't mean we don't have them.
Okay, Dr. Mkhani?
والله اتفق مع الدكتور حسام والدكتور زيبر في النقطه هذه. النقطه اخرى هي قضيه transfer of expertise transfer of trainees from the Gulf states in a free way. But مشكلتنا احنا الانظمه الصحيه تكاد تكون تختلف يعني بين وزارات وبين مؤسسات. هل ينتقلوا عن طريق الGIS؟ هل الGIS هي مخوله بالتواصل مع مؤسسات صحيه في الخليج لتدريب بعض الاطباء في مؤسسه معينه؟ ما اعرف كيف النظره راح تكون في المستقبل. هل لها الصلاحيه في هذا الشيء؟ يعني مثلا انا عندي fellow he wants to do let's say a year or a month of intervention في
نعم. Interruption. I have a comment from one of the audience say if you have speak in English will be better.
Okay, sure, no problem. No, the regarding the transfer of expertise, transfer of trainees, the GIS, does it have the authority to allow communicating and arranging this opportunities for the trainees in the Gulf states? If I have a fellow who wants to do 1 month, let's say in Prince Sultan, should he go through the ministry, go through the GIS? Does the GIS has some sort of authority to arrange this? I don't know.
But you know, sorry to answer, most of the fellowship is not a month. I'm telling you, we don't accept somebody come for a month. I mean, they must be two senior individuals. They could come to us and they talk to a senior to senior and they will stay for a month. I mean, that's a different story. But if you're talking about a junior fellow would like to come to a fellowship, I think you should go for it, regardless where you're going. You go to King Faisal or Bahrain or Kuwait, it has to go for a year. And I think GIS could just only be the agent for the coordination, the approval and things, and I think it has to be done between the institution. But you need a facilitator, and GIS could be the facilitator.
So,
sure.
If I may come...
Okay.
I think this leads us to consolidate behind the GIS. I think the GIS could solve a lot of the issue raised in the last 15 minutes. Rather than just doing our annual meeting, during the rest of the year, if the GIS could make research, for example, more lively. The second point, to make guidelines to be applied for, say, cath labs, regional cath labs, referral cath labs in the countries, and what are the, and then we register, for example, GIS recognized centers, for example, and we communicate with the concerned institution within the GCC. That will help. And I think maybe GIS board should reflect on this by saying, okay, we would like to bring all the Gulf states behind us, and we will be very strong. We will try to help improve the safety of procedures, the safety of cath labs, and then regional referrals, so that people could have the expertise, proctors, and so on from the Gulf.
Excellent, good. So we'll move on to the last point. Actually, nowadays we live in COVID. Part of the changes we see is are changing to online-based education. Everything is different in this time of the year. The way of the hospital setup and how we deal with the patient, the type of patient that we bring to hospital, and even the education and our practice on a daily basis, even our practice with our family is different. So what we start to sense, and actually, at least myself, that things will not be the same in the future. Everything will be different. Our government here in Saudi Arabia, they're looking for almost 20% of the employee to work from home, even after COVID finish. So this will take me to the question that, what do you think about the future changes in the medical health services, including interventional cardiology? Do you expect any changes happen, or after COVID finish, we'll go back to exactly the same? So maybe we'll start with you again, Dr. Abdullah Naimi.
والله تعرف يعني أنا I think I am reflecting a lot on myself and reflecting what is our role and reflecting on a lot of things يعني. I'm not talking about the government side. I'm talking about individuals. So the first point, I found that a lot of my people, patients, needs reassurance. And I think I encourage senior people to give time to those people. There are a lot of patients now who are afraid to come to the hospitals, but will be very thrilled and very happy to listen to their doctor to answer their fears. So and I think this is sadaqah in this month, and this is our community's right toward us, that we should give some to them. So you make some of your time available to the community. طبعا you have to balance this with the family time. But I think it's very important that you specify some of your time for the community, and not only telephones, but also you have to do some work to the community. And the community has to see that you are volunteering in one way or the other, either at the GIS level or individual level and so on. And the second point is, and I think reflecting on the COVID environment, our team who work with us in the clinics needs that family ties, and they need to see our senior looking after them, making sure that they are okay. Maybe they need some counseling and so on. And you know, we have a lot of assets. We have a lot of assets in our team. Maybe you might notice that they came out really with a lot of skills lately. So reflect in your technicians, reflect on your nurses, and make the team spirit more stronger, if I may say.
You know,
I'm gonna take the next.
Fawaz, can I say something?
Sure. Yeah.
You know, the thing's going to change, and I think the major contact with large number of patients is the clinic. And I think many of the cardiac patients, a lot of them are chronic stable. They don't need to come to clinics. We started this telephone clinic a long time ago, like 10 years ago, with an electronic system of confirmation. But we were afraid of somebody give you, we're dealing with patient who possibly will die. And I'm talking specifically about heart failure patient. You know, people with ejection fraction 20, 30%, they're gonna die within 5 years, maybe 30, 40%. And if you die after the phone call, he said, oh, I spoke to the doctor and I died. Is he responsible? But the COVID has forced this practice into the people. In fact, the people like it. Presently, as you know, Fawaz, we do our, what do you call it, telephone clinic or virtual clinic. The virtual, where you could see the patient, like, or only the phone. And I think many of the patients are extremely happy not to come to the hospital. I don't think it's a COVID the issue, but you know, it's to get somebody to transport them to the hospital, elderly people or the women and so on. And if they could get the medication through the post and they discuss with the doctors, maybe you will avoid a large number of outpatients. However, when it comes to your business intervention, it's not going to change actually. I was talking to Dr. Kamal, our Director Cath Lab, and apparently the primary PCI is still on. I mean, it's a good number of patients they're coming. I don't know, Fawaz, maybe you know. So it's basically, this is not going to change. People are going to come because they are sick. I think now the first month they were hit because of the media. The media made the case extremely, I would think, ambiguous. I mean, I had a corona myself 2-3 years ago. I mean, not everybody will get sick. You know, I got it from a patient. So I think procedure should continue back to, but you have to be doing the right things, especially when I was asking this in our hospital, that every patient come to ER has to be tested. It was a major issue. They were not refusing and so on. Now they're accepting it now. After what, 2-3 weeks, they're doing now testing on every patient come to the ER or elective. These extra tests is very important to reassure operators, surgeon or intervention, to become more aggressive back again to work. So that's the way practice should be. I think testing everybody, outpatient, 50% could be run by telephones. And you'll be more cost effective.
So, Fawaz.
Okay, thank you, Dr. Mai. Yes, Dr. Zubair.
Dr. Fawaz, you brought up a big issue, world after Corona. So there's a lot of, issues there. It's a Corona is what? It's an influenza. It's some kind of infection, some kind of influenza. So it's not influenza. It's not, little, maybe faster spreading than influenza, maybe a little more lethal, but we've never said, what are we going to do with life after influenza or life after H1N1? I mean, we lived through H1N1 a few years ago. I got it, my wife got it, my grandchildren got it. We had patients in the CCU who had H1N1. We never said life after H1N1, life after influenza, life after MERS, and so on. I think we have to really insist that life goes back to normal. We have to have some kind of normalcy. I hate this video conferencing, despite being part of it. And really, I've lived dealing with my patients on the WhatsApp and on phone calls over the last 2 months, and I hate it. There's no, it's not real. It's artificial, and you do it because you're that thing that Dr. Abdullah was talking about, so your social responsibility. Well, I don't know about social responsibility, but I'm at the hospital in the morning, and truly we're at the hospital working, which we do, which we're very proud to do, we're happy to do. And then, you come back, there is really no more room for social responsibility, but we do that. We've done that with our patients, but I feel it's artificial, it's not real, it's lifeless. But you're just trying to get through it and get the patients to understand and help them not go to the ER because of the risk of going to the ER. But let's just pray to Allah, pray to God that this COVID is just another influenza or another H1N1 or another, God knows, some kind of virus, that we have to go back to normal life.
Can I come in?
And we should insist on that.
Perfect. Dr. Mkheni?
Wallahi, post-COVID, I think the moment it's over, we'll go back to our clinical practice, which is really important. And we cannot communicate by the internet or by the social media with our patients. Still, patient-doctors relationship should be there. The only thing which will happen, what I expect, that the clinical meetings and international meetings will come down dramatically, and people will that crowdness you see in the PCR or the TCT or the AHA or ACC will not be there. I don't think so for the rest, at least for the next 2 or 3 years. Thank you.
Dr. Hussam, at this point, before we go to question and finalizing the session.
I think the life after COVID goes back as normal. The only thing I've noticed, which I echo Dr. Muayyad, is that a lot of time for us as well, that we do morning clinics, and you find out that a lot of time you spend, to be honest with you, is wasted refilling medications. So refilling medication for somebody who's stable, you can use your time doing something much more efficient than just going to the clinic, saying, Sabah al-Khair, good morning, how are you doing? You're good? Okay, this is your medication. So we have noticed that about 70% of the returning clinic visits are just to refill medications. So if you cut down by 50%, you do it, or your assistant would do it, or your nurse practitioner would do it. We're not ignoring the patient at all. They say, how are you? Everything is okay. Your refill is done and you don't need to come to the hospital. We send you the medication by car to home. So there is a continuation of care. However, we can utilize our time to do something more beneficial on the long term than if you do 2 clinics per week in the morning and you spend 80% of that time basically refilling medication. I don't think that's very efficient for anybody. And in the US, we used to have nursing practitioners doing all of these things. And if there's any problem with the patient would come in to be seen by the physician. So I think with that practice happening, at least in our center, hopefully that will be a change in terms of procedures. And I don't think, and I'm looking forward for this to finish, so we can go back as we were before and busier and even after that.
Excellent. Great points. I'll just go over some of the question here. Some of the question already answered with our discussion. One of the question from Dr. Adi said regarding limiting cath lab, do you have to balance it with the access for STEMI? Like, do you think we should have an authority in each country that's limiting opening cath lab and further allowing which cath lab to be a primary BCI center versus elective cases? So maybe we'll just take one of the, just to answer this.
Sorry, the question limiting.
So I said it's regarding limiting cath labs. But let me make it like this. Do you think that we should have an authority of opening cath labs? Like it's not allowed to, like as we know all, one cath lab is good for 1 million population. Do you think we have to have it in Saudi Arabia or other Gulf area that we should not up to hospital to open more cath lab without going to a command and control center or authority that can decide about it? Plus, if you have a cath lab, do you think each cath lab should do everything? Or shall we prioritize cath lab or make it levels, like level A for structural heart disease and STEMI, level B only elective cases, and complex level C is just type A lesions? What do you think, Dr. Mayed?
Shuf, we tried this many times in the past. And every time we were trying to open it to the subject, the reaction said that we want to prevent expansion of cath lab. I don't think it should prevent, but the cath lab should not be side by side. يعني for example, in Riyadh, we have the military, King Fahd, security, university, and the King Faisal. 5 major institutions within, what, 3 miles, 4 miles? And each one has maybe 4 cath labs. I mean, and I bet you, you know how much costs to maintain a cath lab per year? It's about $500,000 riyal, just to maintain the equipment, plus the staffing. So you could imagine how much the government is wasting to maintain 4 cath lab or 5 cath lab military, 5 cath lab in the King Faisal, where you could do the work in 2. I mean, we used to do 1,000 procedure in the military hospital in 1985 on 2 cath labs. And now maybe they do, 1,000 surgery, which is equivalent to 2,000-3,000 cath lab, all right? And we are the same. As you know, our cath lab is not very efficient. That's why we want to close some cath lab, because there's no need for it. And there's a lot of money, Maintenance, changing the equipment every 7 to 10 years, it costs you about 7 million. The staffing, you need 2 nurses, 1 technician, and so on. So really, there are so many cath lab, totally waste. If you want to open cath lab, like the cath lab they opened recently in the south, I think it's fine. South of Riyadh is very crowded. Our cath lab, National Guard, we cover the east. The number of people beyond the ring road to the east is only like 2 million people. So that's why I was not worrying when we opened National Guard, because there's no service for 2 million people. So I think, yes, you could open the cath lab, but it has to be distributed really well geographically to become economical. And then you have to see how many cases they're going to do in that cath lab. Now there is no cost effectiveness.
Excellent. Very important point. If anyone else would like to say a word on it.
As long as you have expertise running these labs, I wouldn't worry.
But the cost, Muhammad, the cost. I mean,
sure. I mean, we have
I mean, when we designed our cath labs and areas in 1995, we did not want to have, tomorrow we have another cath lab, second floor, the other cath lab, third floor. So they all looked together. We're not using them, basically. It's like locked in, prepared, we don't use them. But as things change and we bought cath lab and other center open, Habib Hospital private, Shemasi, the main national, like the chest hospital, we don't need this cath lab because then they are resistant from the intervention cardiologists not to close because it's a toy. But that toy is very expensive. I mean, you know, if I tell you, you have to pay $500,000 riyal for every year to maintain equipment, plus 2 nurses, plus one. When you talk about management and cost, as we are talking about cost, this is total waste of money. So you have to have the right number for the institution.
Thank you, Dr. Moayed and Dr. Zubayd. A lot of points they mentioned our audience about collaboration between the Gulf area in form of registries, which is, we are working it in a GIS, and I would like to thank all of you that support in GIS and even the audience that make GIS as an authority and umbrella for this. One of the question is, one of the technicians said, where is the technician stand in all of this? Definitely the cath lab and interventional cardiology, they cannot work without technician, radiographer, nurses in the cath lab. They are a major part in our team, and definitely all success, they are behind it. There is a question about hybrid cath lab. Do you need a hybrid cath lab in any place where there's structural heart disease? Maybe Dr. Hussam will take that.
Well, this is an ongoing debate, I would say. I mean, there was a time in which a few years ago, there was a lot of excitement about hybrid labs. And in the new center, we will have a hybrid lab coming up. But I personally feel the role of hybrid labs are coming down, as Dr. Moayed said, because who uses it anymore? It used to be very common to be used before. For example, if you do the structural heart, you can do it. You don't need a hybrid lab. Even if we do the AAAs or the endovascular, I still don't think there's a need for the hybrid lab because to run it and the cost of running it is a little bit higher than the conventional lab. So that's my take on the hybrid labs. There was a big hype for it, and I think it's coming down. I don't know what my other colleagues think about it.
Okay.
Cool. Hybrid cath labs, yes. But hybrid OT, that's the problem, because movement in and out is very difficult. And really for TAVI, you don't need a hybrid hybrid lab. You can do it in the regular cath lab. Maybe for other like the other complex structural heart disease, maybe you need.
Excellent. Anyone else would like to say something?
I think I agree with Hussam that you don't need hybrid cath lab in every. We don't have hybrid cath lab, but if you want to be aggressive and start to do some new technology, new ideas, that potentially could be a high risk. I think it's nice for big centers to have one. Having one doesn't mean you don't use it for ordinary cases. The only thing, it will be set up in an OR, not in an open kind of cath labs. Pediatrics, sometimes they need to move the patient from baby. In fact, children are more than adult. They need to go to surgery with some problem during procedure. And moving a baby or a small newborn from the table to the trolley or ventilator is really a cumbersome for children. So I think you need one cath lab to be shared by pediatric, by adult, for example, infected pacemaker wire. The mortality is 10-20%, okay? This has to be an OR. You cannot do it outside. We do about, I think Dr. Haytham Al-Anizi did about, 30, 40. The number of perforation during procedure is just incredible. It is a laser and perforation, repair and perforation and laser on the same case. Sometimes take many hours. These patients cannot be done in cath lab and cannot be done in the standard OR. So you need one for regional center. Maybe Bahrain need one. for example, if they want to do something new. But they could use it for ordinary cases. Doesn't mean it's only OR.
Excellent. Good. I think it's I went over the question. We have almost 33 questions. Most of it we go over it with our discussion, and I think we answered the question that we didn't touch base on it. So from now, I think it's if you allow me, everyone for a minute or two, just give us the final word, trying to see what he think about this session and some advices to all people who are listening to us. We have almost more than 400 registered with us in this forum. So anyone would like to take the lead?
I'd like to perhaps say something for all the people listening. These are hard times. Just hang in there, and يعني Allah be with us all. It's really tough. And even through these hard times, we need to do research. We need to analyze what we do, what we practice, and how we practice. And this is really so important. And this is one thing that differentiates, and I said this earlier on, between us and our colleagues in the West. We've had part of the success of the Gulf Heart Association over the years is the fact that they've excelled in supporting research, regional research. And we've had several research projects that many of the listeners actually have, and the panelists have been involved in, from Gulf Race, and then Gulf Race 2, and Gulf Race 3, and Gulf Safe, and Gulf Coast, and Gulf Dyspnea, and Kuwait CLAP. And throughout, the past 15 years, those centers, those investigators who have contributed to this work or to these projects have benefited a lot, whether they've benefited locally in changing their practice, whether they've benefited in getting their promotions done, whether they've benefited in being able to present their data to their healthcare providers and so on. So my one advice, and we're in Kuwait, we're embarking on a project and have asked funding for influence of COVID-19 on ACS hospitalizations and the practice of cardiac catheterizations in Kuwait. We're going to compare the months of March, April, May, and June of this year to the same 4 months a year ago, and perhaps 4 months of 2021. And look at what happened, because we know things have dropped down by 70%. And inshallah, once we do that, we'll ask our colleagues to contribute. But there you go. That's, look at what you do, analyze your practice, and take it from there.
Excellent, Dr. Zubair. Who would like to be next?
So, أنا صراحة, I am very impressed that even though we did not present something valuable too much, we think, but the audience has persisted and persevered with us all this 60 minutes or so. The other thing is, there are so many cardiologists could have been in my seat from the UAE. We have excellent interventional cardiologists from Abu Dhabi, Dubai, and the rest of the Emirates. But for a good side of them, maybe I am here in this regard. The third point I would like to finish with, even though COVID is a hard thing, I think it reflected on my side in a positive way in a few things. One of them, this is the first time I did more sport, individual sport, personal sport, for a long time. I have time, so I walk when there is no curfew. So I looked at myself more. I have time with my family, interventional cardiologists, regional, international meetings have taken us away from the family. So now we are staying with the family with 80 to 90% reduction in elective cases, to answer Abdul Matlub bin Musa. and maybe by 38 to 40% reduction of ACS intervention. So we are here in the with our families, and also like this is maybe, for example, reflecting on my recitation of Quran this Ramadan compared to this, maybe alhamdulillah it is increased. So there are some good sides of this time. I wish you all the best.
Thank you. Dr. Muayyad
Just I want to
or Dr. Mohammed Al-Khairi?
just I want to thank you all for all what have been said. So just we stress on, or we conclude that it's more collaboration, more networking in the future, inshallah. And thank you all.
Thank you very much.
Awaz, yeah, I think if I leave the last word for Maya, is my mentor. So I think again, thank you very much for this fantastic discussion that we had. But I think one of the topics that Fawaz we discussed at the beginning when we were trying to narrate this webinar is where are we going in the future of interventional cardiology? Where the younger guys who are coming on board with us, what are they look? I think there are few areas I think which are changing from before. I think number one is the role of, you have to think about a question about the role of diagnostic angiography, which is almost replaced by CT scans, and the utilization of, you should learn how to read the CT by yourself, and what the technology is coming out with the CT, for example, CT FFR, to guide your intervention. That's one area that is, is heated up. People have to learn more about it. The second is, when I started my career, it was balloon and stent, balloon and stent, balloon and stent. And of course, now things have changed, is that people have to focus more on precision PCI, using the imaging, the OCT, the IVIS, the FFR, to contribute all for us to have the best outcome for the lesion that we treat. The third part is, I think we also have to think about, we as interventionalists, we're not only technicians, we also have to follow and read and understand more of the pharmacoinvasive therapies. For example, the utilization of PCSKs in our patients, for example, or using the SGLT2 inhibitors in patients with heart disease and ischemic heart disease. So these technologies it wasn't there when we were doing our fellowship, that it has to be incorporated in because we do practice cardiology as well. The final thought is, and now with even interventional cardiology has subspecialties, and if you're working at high volume center, do you really want to be a CTO operator? You want to be a structural heart disease expert, or you want to be an imaging expert, especially when you work in a big volume center like a hospital, the university hospital. So these are the questions that the people getting into the field have to ask themselves. Do they want to be doing everything, or they want to be really specific? And going through all these 4 pillars that are shaping our practice in interventional cardiology. And again, thank you very much for this wonderful meeting.
Very, very good points, Hassan, and as usual, excellent. Dr. Muayyad?
Yeah, I think there is one issue is important. We don't practice this in the Gulf. The way we brought the technology to the military hospital in the 80s was people coming from abroad for 3 weeks period on every aspect: anesthesia, intervention, echo, EP, cardiac surgery, nurses, and so on. And I think we transferred the technology from the West to the military over a period of 4 or 5 years. We should use the same now because we have enough experience in the Gulf. I think you should encourage people coming to other institutions for 2 or 3 weeks with not the idea to come to do a locum and cover your clinics. He comes with a specific function. For example, you want Dr. Hussam to come to the National Guard, for example. He comes as a locum for 2 weeks, 3 weeks. He focuses only in the cath lab to do CTOs. You bring CTOs for 2 or 3 weeks, and that will transfer technology from Hussam method to us. Imaging, for example, we are very strong in advanced imaging, CT, cardiac, MRI. We have maybe the largest cardiac imaging center, maybe worldwide, if not in the Middle East and Europe. And we are very well trained people. We have 5 consultants, cardiologists. If anybody would like to learn imaging, he most welcome to come. If he's senior, come as a short period. As a junior, come for a year. So you should use the resources within the Gulf that way. As we brought technology to the military a long time ago, I think we should use now the local staff as a senior to move around. between the Gulf countries.
Thank you very much. It was a great time to have you all with us. It's an excellent point have been discussed. We really appreciate it as a GIS board member. And I'm, as personal levels, I'd like to send my thank to all of you for this session. For our audience, thank you very much for allowing us to present to you something useful. Stay tuned. We have a lot to do under the GIS. We are working in a lot of things, master course for interventional cardiology that I talked about it before, and hopefully we'll release it soon. It's will cover all the interventional aspect. We'll have e-workshops. We'll have workshops for nurses and technicians, either weekly or bi-monthly. Inshallah, we'll release it soon, and we'll have a case submission. And by the end, I would like to thank you all and for this success, and appreciate and have a good night for everybody.
Good night.
Thanks to you.
Good
Good
night.
job. Good
Nice,
job
nice,
for us.
nice.